many chests over the years, my way of doing it is going to be much faster than the way you're going to do it. Here's how I suggest you do this today. The easiest way to auscultate someone is in sitting. So the first time you do it in sitting because it'll just make your life simpler. But then I want you to practice it as if it's a real patient in the ICU who can't really move on their own. So it'll force you to practice doing log rolling correctly, okay? You may, for example, get a case on your practical where it is an acute care patient that you need to do a chest assessment, and you find them in semi-Fowler position, and you're told they need max assist for bed mobility. You need to do that correctly, okay? But again, this is how I suggest you practice learning the sequence. What I want you to do is wherever you place the stethoscope, I want you to say the following: the side, the lobe, the segment. Okay? Lastly, what you would expect to hear under normal circumstances. So, when I'm auscultating the chest, I'll place my stethoscope there and try to listen for at least 1 to 2 respiratory cycles, sometimes longer. What you can't do is say, okay, take a deep breath in for me. Okay, yeah, do another one, because then they're going to pass out on you. So maybe what you need to do is place your stethoscope, do 1 or 2 cycles, take your stethoscope off, and let them breathe a couple of regular breaths. And then again, when they're taking deep breaths, it's not a good idea that your face is in front of them. Okay, so either you turn your head away.
For that reason.
Thank you for that.
That's reassuring.
Guys giving me pieces of your lunch on my shoulder.
Big Mac is good.
Very good. So, ready? If you can't see, come up closer. I start. I go right to left. You look forward. I'm good. Okay? I'm going to go under his clavicle. So, right upper lobe, apical segment, bronchovesicular. Left upper lobe, apical posterior segment, bronchovesicular. Apical posterior. Apical posterior, because there is no apical.
Okay. Oh.
Right? Right upper lobe, anterior segment, vesicular. If I move over here, right upper lobe, anterior segment, bronchovesicular. Yeah.
Do you want us checking both?
You don't have to.
Which
Okay.
one would you prefer?
I don't care. But you should recognize it should be vesicular versus bronchovesicular. Okay?
Right.
All right. So now, if I come over here in the same area, I got to account for the heart. So I got to move over a little bit. Right? Left upper lobe, anterior segment. I'm above the 4th rib. Vesicular. Very good. Now, I'm going to suggest do everything anterior, do everything posterior, and do everything lateral. That's one way to do it. Or, if in your mind you want to do all the upper, and then all the middle and lingula, and then all the lower, just be systematic. So in that instance, if I want to finish the upper lobe, turn around for me. That's fine. Now you can stand. I don't know why that's funny, but huh? It's the stereotype of the horn, that's all.
Yeah, exactly.
That's the only thing you're missing is the balloon. Yeah, I know. I used to have it. Anyway, I digress. So, again, I have a pretty good sense of where this fissure line is, okay, by looking at them. If you want to double check it, okay, find C7, count down. This is the fissure line, so I'm going to go above it. Right upper lobe, posterior segment, this bronchovesicular, because I'm between the scapula. Left upper lobe, apical posterior segment, bronchovesicular.
So there's 2 apical posterior, 1 on front, one on the back?
It's the same, but you can hear it from both sides. Now, by the way, do you see how hard I pressed?
Yes.
You see the ring?
Yes.
So I'm now done with the upper lobe, agreed? Everyone's good? Okay, sit back down. So now I'm going to go to the middle and the lingula, okay? So I can either count down, count up, and I'm going to go between the 4th and 6th. And if I go right here, I'm going to say right middle lobe, medial segment, bronchovesicular, because I'm parasternal. If I go right middle lobe, lateral segment, vesicular. If I'm going to go lingula, I got to account for the heart. So I really only have that. I can't differentiate between upper and lower. Okay? Superior and inferior. Sorry. Superior and inferior. But that would be the left upper lobe, lingula, superior and inferior segment. And they would be vesicular. Yes, ma'am.
Even though you can like tell superior, inferior, you just say that's the way.
I would say what I just said, left upper lobe, lingula, superior and inferior segment, vesicular. Okay? So now, what's left? Lower lobes. So again, from here, I can get one segment from each side. I'm going to get the right lower lobe, anterior segment, and it should be vesicular. What I'm going to look for is his anterior axillary line and his mid-axillary line. Okay? Anterior axillary line, mid-axillary line. And I'm going to go at the 5th and 6th rib. So if I find his xiphoid, go across, find his anterior axillary line, and place my stethoscope right there. Right lower lobe, anterior segment, vesicular. And the exact same location over here, left lower lobe, anterior segment, vesicular. If I go into his mid-axillary line, and I go down 2 ribs, left lower lobe, lateral segment, vesicular. Yes?
Yeah.
Do the same thing on the right. So, what's left? Stand up, turn around. That same fissure line, T2 to T4 is its angle that it descends down. If I go just below it, not on his scapula, just below it, right lower lobe, superior segment. Now right where I'm at here, it's going to be bronchovesicular because I'm between his scapula. If I go down a little bit, vesicular. Okay? Same thing on the left. Bronchovesicular, right lower lobe, superior segment. Go down a little bit, right lower lobe, vesicular, superior segment. If I want to get the posterior segment, what I need to do is count up from his iliac crest and get on the right side between the 10th and 12th rib. Right lower lobe, posterior segment. Go up slightly higher on the left. Left lower lobe, posterior segment. Vesicular on both. Vesicular on both. Okay? That's how I suggest you practice learning it. But once you get into the rhythm, literally, go through each of those segments, 1 to 2 cycles of breathing with a little break in between, you should be able to evaluate all of your bronchopulmonary segments in under 2 minutes. The purpose of yesterday was drawing the lines out just so you could get the sense of the landmarks. And I can't stress this enough. You need to do this on multiple people, just like you need to do multiple blood pressures. You can't just do this on a male patient. You need to do it on a female patient. You have to deal with the breast tissue, okay? You got to ask them to move it out of the way. Again, when you're learning with each other, ladies, you got bras on, you have sports bras, which is making it harder to auscultate your chest. Patients will have gowns on. You will always protect your patient's modesty. You will keep them covered, but gravity, quite honestly, is going to let the breast tissue kind of do this out of the way. So it's not going to be an issue. And if you have to auscultate where the breast tissue is, you simply ask them, hey, do me a favor, lift it up. And let's say they can't. They're so lethargic they can't. Then you tell them what you're going to do, and you use the back of your hand. Okay? Listen, I'm going to move your breast tissue, and I have gloves on. I glove with everybody in acute care. They have something I don't want. Everybody does.
That's what you never got. You need antibiotics.
Hey man, they got something in there that I don't want. Okay, when I work acute care, glove with everybody. I don't care if you're doing gait training with crutches. I glove. Back of my hand, asking permission, and then auscultate. Okay. Always ask permission whenever you're going to do anything. When I'm going to put my stethoscope on, I'm going to say, hey, I'm going to be evaluating your chest. Is that okay? So on this particular stethoscope, this is a diaphragm, and so is this. So if you had a smaller patient, you could auscultate with this one. Okay? It's just a smaller, it's a pediatric diaphragm. On some of your other stethoscopes, I don't think only the Sprague Rappaports have the two. The other one, I think it's a Bell. You should be using diaphragm when you're auscultating the chest. Okay? Does anyone have any questions? Was that helpful?
Yes.
Good. Do you need me to show you any of the